So you guys can see. Okay. Got about a minute to go. Let's go test, test, test. All right. So hopefully we get a shear because we're at about looking forward to this. All right. I'm gonna. So what that's gonna do is that's gonna bring a shear up in Teams. Got it. So yeah, we'll go to Teams. Hey, shear. I think your audio will be coming up. I don't hear you yet. So what I have is it's interesting because I've got a really long delay. So I've got like a 10-second delay between when I talk and what I hear come across the screen. We'll make it work. I'm gonna and then when I come to view, I can oops. I'm gonna I'm gonna keep you on the bottom then. Can you guys can you see a shear? I have I have them on the bottom small. All right, so I've got 501. And what I'm going to do is let's give this a try. Let's see how this works and how the format works. And they can't see. Oh, can't see. Okay, let me hit display capture. Yeah, I did. All right, so let me. Can you see a shear? And yes. All right, so I've got on display capture and I've got a shear up on my screen so I can see them. And you guys can't see them. Oh, darn. Oh, I can't see Dr. Mike. You can't see me either? Well, now I'll tell you what I'll do is I- I'll go ahead and start in a sheer, I know you're there in spirit. So I'm not gonna, we'll worry about trying to figure that out later. If you guys can see and hear me, let me know. And what we're going to do is we are going to launch into talking about curing. And I think one of the things about curing is curing actually seems too easy. It's like, who can't cure? And yet, I think one of the things about curing is you can do it wrong. And it's one of those things where ignorance is bliss. The more you know, the more you understand you should be doing when you cure. So when it comes down to curing, we know that we have to add energy to our composites. Our composites are resins. We add energy to that material and we get polymerization or the material joins and chains. And that's where you get the physical properties and you get the strength. The hard thing about that energy, though, is I was just thinking about today as I was curing my composites, is if I don't add enough energy, I may not get those chains to form, which is going to mean my material is going to be compromised. So after all that work we do to get that composite, the preparation done properly, and then place the composite with our adhesives, if I don't cure that final material properly, all the physical properties that we're trying to achieve are gone. We're going to have staying at our margins. And worse yet, we might have the patient who calls us up later and says, ever since you put that restoration in, every time I bite on it or when I floss on it, it hurts. And why is that? Because there could be a portion of that resin that did not cure, and it could be moving or shifting as the patient chews or flosses. And so we have all these problems just because we took for granted that we knew how to use our curing light. So one of the things that we're going to talk about today is how to cure, some of the things to watch out for, and even when it comes down to the curing light, we'll talk about some of the properties we should be looking at in our curing lights. And I was doing some of the math. I was figuring out, and I have it above the screen right now. I'm going to kind of read it. It said if an office was trying to do $1,000 of production an hour in an operatory, and we divide that $1,000 by 60 minutes, our target production would be $17 a minute. Now, if you use a curing light and that curing light saved you 20 seconds per restoration, because we don't have to overlap, we can minimize the number of cure cycles we have to use, or because we get that proper physical setup of our composite, so we have fewer redos to do. So just saving 20 seconds per restoration, that would add up to 80 seconds if we were doing about 4 an hour. So I know a lot of clinicians do maybe 3 to 4 restorations an hour, depending on the size of that restoration. So that adds up to a minute and 20 seconds. And if we go back to our formula that every minute we were trying to produce $17, that 1 minute and 20 seconds would add up to $22 that we're saving, which would be about $177 of savings per an 8 hour day. And for some of you, that's what you're paying a team member. And so by using the right light and by using the light properly and not having any of the problems associated with not curing properly, you're going to save yourself a lot of money. So if you buy a quality curing light, it's basically going to pay for itself in about 2 weeks. And I've used a myriad of curing lights. I was looking around my office. I've got a different curing light there. Up on my shelf, I've got an arc light in the back. I've used lasers. I've used regular bulb lights. I use the halogen lights. And luckily today we have the LED lights. And the LED curing lights have basically all the advantages that we're looking to have in a curing light. So what are some of the things to think about? Well, one, we want to make sure we have enough energy applied. So I have taught courses, and during these courses, they were actually ortho courses, and we were using curing lights to bond our brackets on. And because these curing lights were being shipped all over the country, I didn't spend a lot of money to buy the curing lights. I bought some of the uh, cheaper kind of imported curing lights, and they were, I think, somewhere between $25 and $40. And when you turn that light on, you saw the blue light come out at the end. But one of the things that you can be deceived by is that blue light. Today, the blue light you may need to have a different curing light, a different wavelength, because what happened before is we had the photoinitiators, camphor quinone, that would be cured in that blue wavelength of light. And then as they tried to make our composites lighter in color, camphor had kind of this yellow shade. So they went to uh, put initiators that were more of a clear shade. Well, those cured at a different wavelength, the more the ultraviolet wavelength. And so today your curing light should have at least two wavelengths, the ultraviolet and the blue light wavelength. And then we have even more broad spectrum curing lights that will do even better things for your restorations. And we'll talk about that. But what you want to do is you want to make sure you have curing lights that have the right amount of energy output. Um, why is that? Well, if we don't get enough output from our light, we're not going to get that depth of cure we need. Many times today, I know many doctors are using different bulk filled materials. Some of them are translucent to allow that light to pass through thicker areas of the composite. And some of you are doing bulk fill with a regular composite. Um, and I'll tell you that I've tried that to use a regular composite that wasn't necessarily designed for bulk fill, cured it with a light like the one I have in my hand, and had no problems, no sensitivity, got the right depth of cure, and everything worked out just fine. But that was using a high output type of light. Now, one of the things about a high output light is that sometimes at the tip, you can get more heat generated there. And so what I like is a light where I don't have to lay it right against the tissue. All the high output lights that I've used have the kind of same issue that if you put on your finger and you fire it up, it can get a little uncomfortable. And if you haven't numbed a patient up and you lay that lens right against their gingiva, they can feel the heat. So, what I like is a light where I can hold it away from my restoration, just a few millimeters. If you need to, your assistant can blow a little air underneath that between the lens and your soft tissue and just keep it a little cooler, keep it a little bit more comfortable for your patient. The other thing is a large lens. So in order to have that high output, let's say 1,000 milliwatts per centimeter squared, if the larger your lens is, actually the more light output you have to have because it's being dispersed over a greater area. So they have to be carefully engineered, and then the lenses have to be carefully crafted because as that light exits the end of the curing light, you don't want to be dispersed out because again, if that energy is dispersed, you're going to lose the concentration over your restoration. So we want to have it focused. So those are some of the things that you want to look at in a curing light is that it's a high intensity light that you can hold it away from the tissue just in case there is a little bit of warmth generated at the lens. You want to make sure it's collimated properly so it's not dispersed where you lose the intensity of the light. Um, and you want to make sure you have the right wavelengths. So you have the ultraviolet, you have the blue light wavelengths at least, and then some of the other wavelengths that this is the pink wave curing light. It's actually got four wavelengths. It's got a red and near infrared. And the red and the near infrared wavelengths actually add to get better polymerization. And the near infrared wavelength actually helps to decrease polymerization stress. So remember, I was talking about if I've got a large volume of a composite and I'm going to cure through that composite, one of the reasons why we usually don't teach doing a large volume is you've got the polymerization shrinkage stresses placed on that restorative material. And if that restorative material is placed in a large bulk, you're going to have more shrinkage stresses creating on the walls of your preparation, which can actually take the buccal and lingual cusp tips and maybe tweak them a little bit. So when the patient then bites on it, they get some discomfort. Well, if you use a light designed to decrease the polymerization shrinkage stress, you're going to have more success. So a light like this is really important. Another thing that I like talking about the time savings of 20 seconds per restoration is with my previous curing lights, the lens size, the diameter was maybe 7 millimeters. And so if I was restoring a central incisor and that central incisor was, say, 11 millimeters tall, what I'd have to do is I'd have to put the lens over, let's say, the gingival uh, half of the tooth and then cure for 20 seconds and then move up to the incisal third and cure that for 20 seconds because I could not cover the entire tooth with the size of the lens of that curing light. Well, today with the curing light that I have that I'm using right now, I can cover the entire facial surface of tooth number 8 or 9. So if I'm doing a direct composite restoration or if I'm placing a veneer, I can cure that in the 20 seconds. I don't have to go 20 seconds in incisal or gingival and then 20 seconds on the other half of the tooth that I couldn't cover. So again, I like to have a really large lens there. When I'm doing an MOD on a molar, one of the nice things is that I can get this lens over the entire occlusal surface of a molar and in 20 seconds cure my MOD composite material. If I have a band on that, what I'll do is I'll take the band off and then I'll come in from the buccal and lingual for another 20 seconds to make sure I get the entire interproximal cured well. A light, a curing light like the pink wave is focused to cure to about 8.5 millimeters deep, about 5 to 6 millimeters away from the lens. So again, I don't have to hold this right up against the patient's soft tissue where they may feel that heat. I can hold it away and still be focused right in the center of my restoration. Then one of the things that I never really thought about before, and then I went to a lecture and once I heard this, it kind of made sense if you've got your preparation and it's let's say a DO, so you have your occlusal form that comes across the occlusal tooth, and you have your DO box form that goes down the back. That if it's hard to shine the light directly over the top of that tooth, let's say I come in a little bit of an angle, what's going to happen is if my adhesive, let's say this is the back side of my axial wall, my light's coming this way. All the adhesive and the composite in this area falls in the shadow of my curing light. And so it never really gets cured there. And that could be a reason why our restorations fail or our patients have a lot of sensitivity um, post placement of our restoration. So one of the features I look for is kind of a very low sleek profile. So if I'm placing my MOD composite, let's say in tooth number 19 down here, the patient doesn't have to open super wide. Some of our patients can't open, I wish they could open this wide. They can't open that wide at all. And so what I have to be able to do is sneak this light, come in flat against the occlusal surfaces of my first and second molars, and get that light right over that preparation so we have no shattering in the mesiodistal boxes and all our material and adhesive gets cured properly. So again, if you've got some of the curing lights I've seen clinicians use are curved because they were kind of more designed for anterior restorations. They weren't really designed well to get into those posterior teeth. And so again, to be able to get back there, very low profile, it's nice to be able to do. Then when it comes to cementation of like a crown or a veneer, one of the things that I like a curing light that has what we call tacking tip. So if I come over here, you can see that we've got this tacking tip, and the tacking tip is about a 2 millimeter tip on the surface of that curing light. See if I turn it on, if you can see it better. But it's very small and concentrated. So if I'm placing my veneers, this is another way to save lots of time. Is I'll put my veneers on with my veneer luting cement, then I'll bring the tacking tip in and tack that veneer in place. So what I'll do if it's a prep veneer where I'm having to worry about gingival health, I'll bring this right into the CJ, the gingival margin where the tooth and the veneer come together, and I'll just tack it for 3 seconds. And by using a small tacking tip, you're only tacking a very small circle of that luting resin to hold the veneer there so it doesn't move. But all the luting cement that's on the mesial and distal of that veneer, it remains unset. And because it remains unset, I'll go in there later. I can floss, I can remove all that composite. And then I come in and do my final cure with my 12 millimeter lens. And now you can see how large a surface area that is. So what I'm able to do when I'm placing veneers is place the veneer, tack in place with my tacking tip so it doesn't move or fall off. Then I come back, get them all placed. Then I'll wipe off all the excess. I'll floss through all the interproximals. And then I'll come back in with my large head and just cure them all. And again, because this is a 12 millimeter head and most of the anterior teeth are no more than 11, I can cover the entire veneer and cure that within 20 seconds, whatever is recommended for the cement that you're using. So that's the tacking tip. When we're doing direct restorations, as I go around and talk to different clinicians, they'll come up and ask during the breaks. Typically, they'll say, "Hey, when I do my direct composite restorations, I do everything like you just described. I put my matrix down, I burnish it up against the adjacent tooth, but I still get contacts that are not as tight as I'd like them to be. What's the solution for that?" Well, we've got these contact type of tips called the tight contact curing ball tips. And so basically it has a ball shape on it. And once you get your matrix down in place, you can put your composite down and actually lay this ball on top of the composite, press the matrix band up against the adjacent tooth. And again, just for 3 to 5 seconds, fire that light. It's going to focus it in a ball shaped lens there. And it's going to make sure that our composite and the band is right up against the adjacent tooth. Then it's going to set, layer in the rest of your composite. And when you take your band off, you're going to have a really nice, tight composite contact. So again, these are just tips that you can slide on and off. This is, again, the pink wave curing light. And it's going to save you a lot of time. You're not going to have that open contact or loose contact. And I know it happens to me when you have a contact that's not as tight as the patient would like. Guess what they do is they come back for the next prophy appointment and they'll point out, every time I eat, I'm getting large chunks of meat that go down the side of that tooth and it gets wedged in there, and then I have to floss it out. And of course, we just always remind the patient that's the way it was designed so that they would floss more. But it irritates them. So a lot of times we then have to take that out and we have to replace that composite and tighten up the contact. And again, by having a contact tip like this, it'll help minimize the occurrence of that happening. Again, saving you at least 20 seconds on that restoration. Now, the other cool thing about this light is it has all the different modes because we talked about it. We're trying to polymerize this material. I typically will do it in a 20-second standard mode where I hit the button and for 20 seconds the light is on. And I'll hold that over the restoration. Now, because these lights are so bright, I try not to look at the light and I'll use the protection that comes with the light. Or if you don't like doing that, make sure that you have this lens right over the preparation, that you secure it with your fingers over the area that you're trying to cure, activate the light and look away. But you don't want to be looking at lights like this that are this bright. It could cause injury, as any curing light. It could cause injury to your the eyes being repeated. We've got a ramp where we'll start out with a lower power, and over the 20 seconds, the power will slowly ramp up. Again, it just kind of depends on what the philosophy that you have about your curing is. And then we've got a boost mode. So in 3 seconds, we can hit that composite with a lot of power and cure it very rapidly. So some doctors I know like that boost mode. In the standard mode, we're putting about 1500 milliwatts per centimeter squared. In the boost, we're going up to about 1700 milliwatts, which is a lot of power. Again, typically I just use the 20-second standard mode, but you can adjust the time. Usually go 20 seconds. I just like to make sure. I tell my patients I like my composites all really well done, not rare sashimi style. I like it well done. Just to be sure that I get all the physical properties of that composite that I want. Another nice feature, and there's a tip for that, is an interproximal diagnostic lens. And so this is the pink wave curing light. If I hit the button, has a diagnostic transillumination mode. So you can see that we've got a bright white light. So if I've got a patient that comes in and they mention, hey, when I bite down this tooth, it hurts. Or maybe we probe and we have a deep pocket. So I'm thinking, well, there could be a vertical fracture in that tooth. What I'll do is I will transilluminate the tooth with a very bright light. So having a pink wave curing light will help me with the diagnostics. Having a tip that will focus that light. So now I can come in from the buccal, I can come in from the lingual, I can kind of come in from the occlusal, mesial, distal, whatever the situation may indicate, but I can concentrate that bright light and come in at different angles and look for different fractures in the tooth itself. So we've got the three different modes. We've got the standard, we've got the ramp, we've got the boost, and we have a transillumination mode. The other nice thing is that the pink wave curing light, because you might be coming in at kind of a low angle, we've got a power on button on the top, and we have a power on button on the bottom. So you've got the two sides you can activate depending on how you're holding this. It's a very light curing light, so you're not going to have a lot of stress on your wrist or your hand. And it has an inductive charging base, and so this would typically be plugged in. What we typically will do is just take it out, using it all day, and at the end of the day, it just goes back into the cradle. It'll make it through, in our practice, it'll make it easily through an entire day. So those are some of the features to look for in a curing light. Make sure that you've got the right intensity. Make sure that you're bringing it over the restoration and you're curing it so you don't have any shadowing of any of the walls of your preparation so that you get the best physical properties of your composite. Make sure that you're saving time by having a large lens. Don't have a curing light with a small lens where you have to do a lot of overlapping strokes to be sure that you get everything cured. Make sure that you've got the right wavelengths, the ultraviolet, the blue, and then having the red and the near infrared are really ideal for the depth of cure. So we have the high intensity, we've got the low profile, we've got the power and the wavelengths. Um, I think those are the biggest things to follow through when you're curing your restorations. We talked about tacking tips. We talked about veneers using a tacking tip. We talked about using a direct restoration with a ball contact tacking tip to make sure you have good tight contacts. Just remember, um, as I was placing my direct composites today, I was looking at the composite, I was shining my light, and I was remembering that this is what was activating, curing, and hardening my composite restoration. If I wasn't hitting with enough energy or for the right amount of time, something within that composite's not going to be fully cured. And if it's not fully cured, that restoration is going to be compromised. So what I want you to do is make sure you use high quality lights and you apply the right amount of light. Now this is kind of the first YouTube live we're doing. We're just going to be bringing information to clinicians. I'm a wet finger clinician myself. I just got done as we started this. Got we're I'm in California, so at 5 o'clock California time is when we started this YouTube live, and that's actually when I got done seeing my last patient. So I ran over here to spend some time with you. What we're going to do is we're going to cover even more topics to make your dentistry, both restorative dentistry and your endodontic phases of dentistry in your practice, easier. What we'd like to do is get some feedback. If you have ideas of topics you'd like us to cover, things you would like us to clarify or uh, change to improve, so you'll watch us, please send those comments over. Anyway, it's been great to spend this time with you. I'm going to sign off now, and I look forward to seeing you all next week. Thank you very much.